I'll start talking. Given that we're running a bit behind time, I'll be brief and focus on getting some key messages across. I was going to do a bit of a Q&A, but I'll stick to the key messages initially. So the idea of this short talk is that I wanted to give you a little bit of a window into the challenges that we have in neonatal clinical trials and some of the alternative forms of consent that have been used. So I'll firstly talk about the challenges of consent in trials for, within neonatal care. So in neonatal medicine, where we deal with across the world, there are approximately 15 million babies who are born preterm each year. And so that's below 37 weeks of gestation. And of those, 1 million will die, unfortunately, despite current medical care. For us in Australia, approximately 1 in 10 infants are born either preterm or unwell and are admitted to neonatal units. And for many of those babies, they need to have interventions done urgently, either in the delivery room, if they need resuscitation, or in the first few hours of life. And while the majority of infants do well, we still have a high rate of mortality or long-term disability in the most extremely premature infants. And unfortunately, pregnant women and infants are often excluded from research, and particularly the sickest and most premature infants are often excluded even from neonatal specific clinical trials. And that means that many emergency neonatal therapies are never rigorously tested. And most of the medications we use are actually used outside of their terms of license based on extrapolation from adults and older children or from animal data. And so I really like this quote that from a neonatologist back in the 90s, that newborn resus has evolved based on extrapolation and assumption rather than clinical measurements. As you may know, the NHMRC national statement is being updated, and an important change in section 4 is the placing of more importance on the need for research to include groups considered at greater risk, like pregnant women and infants, rather than excluding them on the basis of perceived vulnerability, because we currently otherwise have a situation where we have most of our care not having a high evidence base in these vulnerable groups. So why is consent sometimes so tricky in neonatal research? The first reason is that research often has to happen in an emergency setting, and I've mentioned the delivery room space, as well as emergency treatments or urgent treatments needing to be given relatively quickly. And there are issues around opportunity, feasibility, and ethical appropriateness. So a bit similar to what Beck was saying earlier, that often we have a lack of time, not always, but a common situation is that a woman will come in with threatened preterm labor, and she may go on to deliver very quickly within minutes or hours, which makes a prospective informed consent approach impossible. Or she may then sit on the ward and deliver days or weeks later, or not deliver a preterm at all. So the other issue is parental absence. So while the mother may be under anaesthetic quite urgently for an emergency cesarean section, and the father or the partner may not yet be in the hospital. So that's also an issue. And even when they are present, like I said, there are things that diminish decision-making ability, like being in labor, being in pain, affected by medication, and just the anxiety and distress of being in an intensive care environment and having a very unwell infant. So therefore, parental presence doesn't always equal an ability to participate in an informed consent discussion. The challenges really with prospective consent in emergency research in particular, there are two main issues. The first is around slow recruitment and recruitment failure, and that's unfortunately common in prospective consent only trials. The second issue is around biased patient recruitment. So we know from lots of studies that have been done in neonatology that the patients who are consented for trials are a subgroup of patients, usually about just less than 20% of all possible eligible participants who then consent to trials if you just approach prospectively, whereas the mothers who are missed tend to be the younger, less educated, have less antenatal care and less protective medication for the fetus before delivery. And for the babies, the ones that are missed from inclusion or approach to trials tend to be more preterm, smaller, more unwell, and tend to have a higher mortality and morbidity. And we know actually from a lot of subgroup analyses of big trials that have been done that because of that biased recruitment sample of more well patients within studies, the results are therefore not applicable to the smaller and sicker babies who actually are most in need of the study intervention, which leads to wasted research and lack of people accepting and taking on those research findings. So how can this be overcome? Well, first of all, we can try and enhance existing prospective consent methods. And we've already heard a little bit about simplifying consent forms and the importance of that, as well as educating researchers to be able to do it more efficiently, more effectively when parents are in a difficult situation. However, the other approach is to think about alternative forms of consent, and there are a few possible pathways. One is an opt-out consent process, and the other is a consent waiver, with or without prospective assent, and with or without approaching for consent to continue the trial or continue collecting data. So that's sometimes called retrospective or deferred consent, although that's a misnomer really, and it's not wording that's actually present in the NHMRC. So it technically is a waiver with consent for ongoing participation. So I won't dwell too much on the definitions because Elspeth has mentioned them, but opt-out consent has been available in Australia for a while as an option. It's meant to be for low-risk studies. Data should be non-identifiable, and it's meant to be for studies where they have to be of such a scale and such a large number of participants that using prospective consent is not practical or feasible. Study researchers need to be providing appropriate information and giving a reasonable time period for people to have an opportunity to decline. And so that by itself excludes true emergency research and is often used for more low risk but non-emergent clinical trials. So there are some examples there about those, and I'm happy to kind of describe them a little bit more, but they tend to be, or what they all have in common are that they are all comparative effectiveness trials of two different accepted standards of care that are being used, and the studies are looking at which of those two accepted treatments are superior or which one is safer. So they're not novel intervention trials. For a waiver of consent, as I mentioned, there can be a waiver for the study treatment only, and then an approach for consent to continue collecting data or to continue the study treatment if it's ongoing, or there may be a full waiver of both treatment as well as collection of data afterwards. And again, what the NHMRC talks about is that research should be no more than low risk. The benefits should justify the potential harms of not seeking consent, and it should be impractical to obtain consent. So I want to focus on when is a trial low risk, and the previous speakers have mentioned that as well. But for me, I find it very useful to think about non-therapeutic versus therapeutic research. So for non-therapeutic research, such as a blood test for a disease biomarker, it's arguable that there should be minimal or no risk to the participant because they don't stand to benefit from the intervention itself. Whereas for therapeutic research, where you're testing two different treatments or a treatment and placebo, it comes down to whether it's a novel treatment. And in that case, I think that there is additional risk above routine clinical care. Whereas for comparative effectiveness trials, what are sometimes called pragmatic clinical trials, again, the argument is that they have minimal additional risk above routine care. And this view is actually now accepted and reflected in lots of different countries' research ethic guidelines. So in the US, England, and Australia, this is described. So there are lots of examples in the neonatal space of studies that had a waiver of consent for the study treatment, and with an approach retrospectively or in a deferred consent model for consent to continue collecting data. And and interestingly, not all of these are comparative effectiveness trials, but they're all either resuscitation interventions or for very urgent interventions that need to be started in the first hour or two of life. Whereas trials that have had a full waiver of consent, there's been a few of them in neonatology, and most of them are more recent. What they all have in common is that they're all comparative effectiveness trials, and again, most of them are resuscitation interventions. So what are the possible ethical concerns with the waiver of consent? First of all, there is a potential for psychological harm arising from infringing on a patient's right to autonomous choice. So for that reason, it needs to be a low-risk intervention and to have a high social value of the trial. And what is meant by a high social value is not only having an ability or a likelihood of generating real-world evidence about improving care or reducing costs, but there should also be a high probability of uptake by clinicians or decision makers. The second interesting point is that actually patient preferences for how much choice they want will differ for different treatments and different specific clinical trials, and is likely to be different for different patient subgroups or vulnerable populations. So that comes to the importance of having consumer involvement in trial design and not just kind of involvement in assessing consent forms or assessing the trials prior to an ethical review process. And that's because particular patient groups may also be less trusting of healthcare and research. So having their voices is also really important about what types of consents are appropriate. The second possible ethical argument against it is the slippery slope argument, where alternative consent modes will be increasingly used for convenience rather than true necessity. And there are two possible responses to that. The first is to think about the example of waivers of consent that are currently used for observational research. And in that case, the scope is clearly defined by law and guidelines, is transparent, and is done under tightly controlled conditions. So that hasn't eventuated in terms of a slippery slope. The second possible response is what's in the National Ethics Guidance in terms of the requirement for open publication of information on all trials which are granted alternative consent. So I want to briefly touch on what parents think about alternative forms of consent, because that's very important. There was a good review of studies of both adults and neonatal trials around this, people who were approached after after involvement in research with alternative forms of consent. And they, in summary, they want to know that they're entering a study. That's very important. However, in the NICU setting, just over half of people who were asked considered prospective consent as too stressful and unwelcome. And interestingly, only 1/3 of people actually recall the antenatal consent process at all after they're approached. In most studies, the majority of parents or participants were accepting alternative consent models if research was not possible without them. But when the infant, in neonatal studies specifically, when the infant was less unwell, the benefits of the trial were seen to be less, and therefore reducing autonomy was perhaps less justified. So thinking about where we go from here, I think it's very important that even with alternative forms of consent or waiver of consent, it's important to maintain respect for participants and parents. And that includes things like exploring opportunities to inform about potential emergency research during routine antenatal care. And that's easier said than done, but it's certainly something that people are trying to do a bit better. Employing opt-out consents rather than a waiver for things that are low risk but non-urgent, And then thinking about mixed models of consent, and this is really interesting. There's been a few trials now that have had mixed models where for women, for example, who are at risk of preterm birth, who don't deliver immediately, they're approached for prospective informed consent, whereas women who deliver very quickly, they go into a deferred consent pathway or a waiver pathway for initial study treatment, so like a resuscitation intervention, and then are approached afterwards for consent to continue. So the benefits of that mixed model is that you maximize opportunities for autonomy where it's present, while avoiding biased recruitment, which is the issue with prospective only consent. However, the risks are potential confusion and loss of trust when you've got two sets of parents who are recruited in two different ways. And the approach to that is having good communication training for research and clinical staff to explain why there is potentially an ethically appropriate difference between the two. So I've got some take-home messages there, but I think the best thing to do is probably go back to Sophie. I'll leave this slide up.
Thanks, Amir. It's interesting, all the talks today have sort of really alluded to the importance of considering how we do consent, not just how we do our research, but how we do consent in our specific population. And I think the changes to the national statement for Section 4 that are not yet into effect, but what you've alluded to, have really flipped the idea of making sure we protect the vulnerable to making sure we don't exclude people from research because of a vulnerability or a perceived vulnerability. And I think that's a really good change, because as you rightfully pointed out, we can't have evidence-based care, evidence-based medicine without research that is inclusive. So thank you so much, and sorry to rush you through.